Hello, and welcome to this video on the Easter eggs of acute heart failure. My name is Alan Shim, and I teach, do, and study all things ultrasound at UCLA. I'll be your host also for the next 15 to 20 minutes. First, I have no financial conflicts of interest, although I am very interested in the management of acute heart failure, and I also like finding Easter eggs. So what do I mean by an Easter egg? It's something that can be painfully obvious, but unless you are astute, you will entirely miss. It's a reward, a pearl for a careful observation. For this talk, I'll discuss some cases and reveal some Easter eggs that you can take and use on your next acute heart failure patient. By the way, if you have not already, please watch Jonathan Morales' excellent acute heart failure ultrasound video. It covers all of the ultrasound techniques that we will mention in this video. So let's get started with our first case. You have a 75-year-old with the not-so-rare trifecta of COPD, end-stage renal disease, and congestive heart failure. He presents with 3 days of dyspnea. He thinks this is similar to his prior COPD exacerbations, but he's not 100% sure. His vitals are notable for mild tachycardia, tachypnea, and hypoxia. After giving him some supplemental O2, you decide to listen to his lungs. You hear, shoot, were those rails? Maybe some wheezing? Nah, I think those were rhonchi. Sometimes it's not so clear as to what is new or old, as well as due to the patient's body habitus and the colorful sounds in a busy ED. Yeah, you can order your chest x-ray in labs like a BMP and a trope, but that's going to take some time. And why wait when you can make your diagnosis at the bedside and also start treatment at the bedside? Sometimes we just try to treat all possible causes of dyspnea. That might not hurt the patient, but it seems wasteful, doesn't it? Now, if a wonder drug like lasofoxalbuterol ever were developed, that would change the game. Speaking of changing the game, the first Easter egg. That poor little girl, she doesn't even know that evil surrounds her. I've sprinkled this talk with these mutated hell bunnies to help sear some of your brain cells so that you'll remember these pearls better. So the first Easter egg is that you can make the diagnosis of pulmonary edema very easily and quickly at the bedside. If you see 3 or more B-lines in both lungs, you have about an 85% positive predictive value for pulmonary edema. I typically look at lung zone 1 here on both chests with the caveat that this is the most anterior zone, followed by zones 2 and 3. So you're likely to get more B-lines as you progress from zone 1, 2 to 3. And these are the B-lines right here. So they're vertical lines coming from the pleura and going all the way down to the periphery. So how good is ultrasound in detecting pulmonary edema? According to this meta-analysis, it's very, very good. Like you're done, drop the mic good. 94% sensitivity, 92% specificity. This is way better than a chest x-ray, which has sensitivities and specificities in the 50s and 80s respectively. All right, let's dive now into case 2. We have a 75-year-old man with a history of heart failure who has a classic presentation for acute heart failure. Orthopnea, bilateral extremity edema. He also has a precipitant as well, having run out of his meds. His vitals and chest x-ray are here. Chest x-ray shows increased interstitial markings and cardiomegaly suggestive of some wet lungs. So what would you do next? Yeah, nitroglycerin and furosemide are good choices. You give him this and shoot. His blood pressure has dropped and now he's altered. He's in cardiogenic shock. So you start norepinephrine and his blood pressure and mental status perk up, but you have to admit him to the ICU. Now, was this preventable? Easter egg number 2. Those kids are going to make a fine meal. Had you performed your bedside echo to assess systolic function, you would have seen this. Terrible, severely depressed systolic function. This patient has severely reduced systolic function or brittle heart failure, and these patients are at risk for developing cardiogenic shock with either vasodilator and or diuretic therapies. Often these patients will have cool extremities, but not always. If you do suspect this, Often starting patients on an inotrope will help to perfuse their kidneys, and that alone, or in conjunction with a vasopressor and diuretics, will help them to diurese. As explained in Jonathan Morales' video, there are multiple phenotypes for acute heart failure. We like to throw nitroglycerin and Lasix for every acute heart failure patient, but often that is the wrong approach. As in the case of this patient who has the brittle or low blood pressure variant, we need to think about making the diagnosis of the right subtype and tailoring treatment accordingly. By the way, this is a great article on the various acute heart failure syndromes. If you read it, I believe it will change the way you think about acute heart failure. So some of you might be thinking, I don't need ultrasound. I can diagnose all of these types with my physical exam. Well, this is data from Mark Dresner, who is a well-known heart failure cardiologist, and this is from a heart failure journal. The bottom line is the physical exam is mediocre at best for diagnosing acute heart failure subtypes. This is another study by another well-known cardiologist, Sacha Bhatia. Again, there's no way on physical exam to tell the difference between acute heart failure with preserved or reduced systolic function. Even if you look at something with statistical significance like ankle edema here, still over half of these patients in either category have this finding. This is why ultrasound is important. It can diagnose the type and, as we'll learn later, the severity of acute heart failure. So just a brief recap on systolic function interpretation. First, just stick to the categories and don't try to estimate EF. This is a well-validated approach for non-cardiologists, and really there's no benefit to saying an EF is 45% compared to 40%. It's still reduced. So instead, ask yourself 3 questions. Does that anterior mitral valve leaflet hit the septum? Do the walls of the septal wall and inferior wall of the LV contract by more than 30%? And does this chamber right here, does this change in size during the cardiac cycle? So this is a normal LV. This is moderately depressed right here. And this is severely depressed. So let's go on to case 3. We have a 63-year-old man with a history of hypertension and CKD who presents with dyspnea for the past 6 hours. His blood pressure is severely elevated and he's tachycardic and hypoxic. This time you perform your lung and cardiac ultrasound. What are these? Yes, B lines. He's got B lines bilaterally. So your suspicion of acute heart failure is confirmed. But what's this? His systolic function looks, well, mitral valves hitting the septum, the septal wall and inferior wall are actually contracting pretty well, and the chamber is changing in size. It's actually pretty normal systolic function. You decide to treat him for hypertensive emergency with BiPAP, a nitro drip, and furosemide, and you admit him to the ICU. The next day he feels better. He is started on his oral BP meds, and his blood pressure improves. He's got good diuresis. But then you repeat the creatinine, and it's elevated. Now you're stuck. Is this patient dehydrated or over diurese? Or is it still cardiorenal? Maybe you can give a bolus of fluids and recheck the creatinine. Or maybe he needs more Lasix. This worsening renal function after acute heart failure has been well described because it happens to roughly a third of patients with acute heart failure that are admitted. It doesn't usually affect mortality, but it does increase the length of stay by about 3 days. So what happened? How do we prevent this? Easter egg number 3. A vintage photo to show that Easter bunnies have been terrorizing kids for ages and ages. So the patient had another variant of acute heart failure, flash pulmonary edema, due to increased afterload. The duration of symptoms and significantly elevated BP, as well as normal systolic function, should tip you off that this is not a fluid overload problem, but a redistribution problem. The LV isn't able to generate enough pressure to pump blood efficiently into the systemic circulation. Thus, blood backs up into the left atrium and subsequently pulmonary circulation. As a result, there's also decreased renal perfusion, and because of the renal angiotensin system activation, the blood pressure continues to increase, and over days there will be increased fluid overload. However, in the first 12 to 24 hours, there is minimal fluid overload. So the treatment should emphasize blood pressure management and not diuresis. In fact, most of these patients will improve dramatically with BP management within the first 6 to 24 hours. During admission, we tend to over-diurese these patients, hence the dog chasing their tail spiral of worsening renal function. Let's now go to case 4. We have a 42-year-old long-term smoker and morbid obese patient who comes with peripheral edema and dyspnea for 1 week. You do your ultrasound and find this, a dilated IVC, and on lung ultrasound, just A lines, no B lines. His systolic function, which isn't displayed, is actually normal. You decide to get a little crazy with your echo skills and obtain this apical 5-chamber view. That RV doesn't look like it's contracting very well. But the apex here looks like it's still working pretty okay. So what is this? It's McConnell sign, which is RV hypokinesis with apical sparing. Now there's some debate on the pathophysiology, but I want to note that it is not specific for PE. In fact, 2/3 of patients with McConnell sign have either RV infarct or worsening acute on chronic pulmonary hypertension. So if the EKG does not show a STEMI and there's no evidence of PE, and in particular the patient has a history of pulmonary hypertension, the likely etiology is acute on chronic right ventricular failure. If you're getting hungry, I promise, I am almost done. So RV failure is probably the most challenging type of acute heart failure to manage and terribly complex. So I'm not going to discuss the management of RV failure step by step, but instead how I think about it. I think about it as one long tube with chambers. Every chamber can contribute to the acute RV failure. So assess each chamber and tailor treatment for that chamber if there is evidence of dysfunction. So other Easter eggs of acute heart failure. First, know the patient's past echo results if available. It will give you a lot of information on the likely type of acute heart failure syndrome. Second, find the precipitant, and more importantly, rule out ischemia and, if indicated, dissection or pulmonary embolism. Third, consider the duration of symptoms, because this will likely be the duration needed for recovery. Patients that have acute symptoms, let's say less than 1 day, will likely need 1 day or less of treatment to return to normal. Patients that have had progressive symptoms for a week or more will likely need several days to weeks to get gentle diuresis to get back to normal. Thank you for your attention. Here's my email. Let me know if you have any questions or comments. Now, if you're hungry for more, put on pause and take a quick break. Because there is a bonus section, and it's the ultimate Easter egg. Did you know that we can potentially discharge up to 50% of acute heart failure patients? There are some complicated algorithms in place that help to predict potential for discharge, but none with the simplicity and elegance of, yes, you bet, ultrasound. In particular, it involves the study of LV filling or diastology. So let me take you on this journey of diastology. This is an apical 4-chamber view with color Doppler turned on and the speed slowed down. Red or orange color means blood is flowing into the LV from the left atrium. And blue color here means blood is going away from the LV and into the aorta. Look at what's happening. Note systole and diastole. And in particular, note that there are 2 phases to diastole. There's an early here, followed by a late flow right here. In early diastole, the LV is expanding, and that creates negative pressure in the LV. And as a result, the blood is sucked into the LV from the left atrium, just like pulling on a plunger in a syringe. Normally, early diastole, when the LV expands or relaxes, is responsible for up to 75% of LV filling. Then you have atrial contraction or late diastole. This generates positive pressure in the left atrium so that their blood is pushed into the LV. This late part of diastole, or the atrial contraction phase, is only responsible for up to 1/3 of the LV filling. Remember that diastole has 2 phases and 2 mechanisms or gradients that lead to LV filling. First, the suction effect of the LV expanding, and then the pushing effect due to left atrial contraction. Now, when we use pulse wave Doppler and tissue Doppler imaging, as discussed in Jonathan Morales' video, we're looking at blood and myocardial velocities, respectively. In normal diastology, early diastole is responsible for the vast majority of LV filling as a result of the LV's ability to expand and create a suction effect. This is why the E velocity here is greater, and the E prime velocity is also greater than the A and A prime. Just a quick but important note on early diastole. This is often referred to as LV relaxation, and it connotes a passive process. This is far from the truth. Early diastole is very energy dependent. Remember that during systole, an ATP molecule is phosphorylated into ADP and you have contraction. In order to have the LV relax or expand during diastole, more ATP is needed in order to bump that ADP molecule off. This process is attenuated with age and acute myocardial ischemia. So often patients with advanced age or MI have impaired relaxation as their baseline diastology. This is what impaired relaxation looks like on pulse wave Doppler and tissue Doppler imaging. The LV can't relax, so the E and E prime are reduced, and the atrial contraction phase of late diastole tries to compensate, so that is why the A wave and the A prime are greater than E and E prime. Note that this is the new baseline diastolic function for many people with congestive heart failure as a result of hypertension, MI, or advanced age. The left atrial pressure, as we will discuss shortly, is normal in impaired relaxation, so there should not be a backup of blood into the pulmonary circulation, and there should be therefore no pulmonary edema. And remember that impaired relaxation, the atrial contraction picks up the slack. It tries to compensate. But because the LV can't expand or relax well, over time and due to slight derangements like increased sodium or not taking meds, the atria will tire out. The atrial contraction won't be able to compensate anymore, and there will be more and more fluid that backs up into the left atrium after every cardiac cycle. This increased left atrial pressure will lead to a change in the way that the LV fills in early diastole. Instead of that suction effect from the LV, you now have such elevated pressures in the left atrium that when the mitral valve opens, all that blood will rush into the LV, much like shoppers rushing into a store when it opens on a busy holiday. So on pulse wave Doppler, the E wave will rise again above the A wave because of the increased velocities during diastole. But the E prime as well as the A prime will continue to diminish because the mechanism for filling is less due to myocardial relaxation or atrial contraction, but due to the passive pressure gradients between the left atrium and left ventricle. If the left atrial pressure is severely elevated, say about 25 or 30, the E wave will be more than 3 times the size of the A wave, and often the A wave will even be unrecognized. So an important concept to grasp is that the more severe the diastolic dysfunction, the higher the left atrial pressure rises, and the higher the E wave will be, whereas the myocardial velocities will actually still be diminished. So as emergency physicians or general internists, why do you need to know this? Well, because we know that a patient's diastolic function in acute heart failure does change with therapy. We can get an idea of flash pulmonary edema or poor systolic function phenotype with the patient's presenting blood pressure, duration of symptoms, and systolic assessment. We can also detect pulmonary edema, and we can also estimate right atrial pressures or severity of systemic congestion with IVC ultrasound. If we can estimate the left atrial pressure, we have a way to quantify the severity of acute heart failure. These are abnormal pressures right here in acute heart failure. So if we can reduce afterload and initiate diuresis, we know that we can normalize left atrial pressure, and if we do this, we can reduce pulmonary congestion and systemic congestion, and therefore we have forward flow again, and the patient will improve. Now, how do we do this? Well, we can estimate left atrial pressures with the formula E divided by E prime plus 4, with the E prime being an average of the lateral and septal annulus velocities. Now, there are some exceptions to when you can't rely on this formula, like when there's significant mitral valve disease or patients that have a left bundle branch block or a PACE. But most patients with heart failure don't have these conditions, so it can be used for most CHF patients, especially the patients with mild presentations or tremendous improvement with therapy, or those that you're thinking about discharging. This is a recent study that shows that EtoE Prime does change in acute heart failure. It changes more noticeably than BNP or IVC, and it is well correlated with actual patient self-reported dyspnea severity. Know that while we use EtoE Prime as an estimation in left atrial pressures, it's actually been well validated as a prognostication tool in all patient groups, including post-myocardial infarction, heart failure with preserved EF and reduced EF, and even in the general population. This is a Danish study where they performed thousands of echoes on asymptomatic patients and found strong associations between E prime and 10-year risk of cardiovascular outcomes. So EtoE Prime and diastology is powerful stuff. Knowing this, I do this routinely on all my acute heart failure patients, especially those that respond well to treatment and could potentially be discharged from the ED. And we think you can do this in your emergency department, ward, or OBS unit. Our goal is to get you there where you are confident in your ultrasound skills to evaluate the type and severity of acute heart failure so that you can direct your treatment to the type and also assess whether or not they are suitable for discharge. So here's a hypothetical case of how this will work. Let's say you have a patient with 2 days of orthopnea and increasing peripheral edema that is consistent with his prior acute heart failure presentations. You find his systolic function is moderately depressed, he has B lines, and his IVC is plethoric. You estimate his EtoE Prime, and it is about 15, so his left atrial pressure is 19. It's a tad elevated. You diagnose him with acute heart failure with decreased systolic function. You give him targeted treatment with nitroglycerin and furosemide. And because his severity isn't that bad, you don't think he's an automatic admission, like someone with gross peripheral congestion or brittle heart failure. So you decide to observe him in the ED or OBS unit, and after about 12 hours of therapy, he has about 1 liter of diuresis. He is also evaluated and ruled out for myocardial ischemia and other badness, and you find out that his precipitant is that he's been to several holiday parties with increased salt and alcohol intake. So he feels a lot better, and he wants to be discharged. You repeat your acute heart failure ultrasound, and if there is no improvement or worsening, you could admit him. However, his B lines are improved, his IVC variation increases, and now his EtoE Prime is 10. So you're confident that his left atrial pressure has normalized, and his pulmonary congestion and systemic congestion have improved. He has his medications, and he has good follow-up as well. So you feel good about safely discharging him and avoiding another costly hospitalization. So thanks again for watching this video. We believe that this acute heart failure ultrasound protocol will work, as the foundation for each component in the literature is robust. What has not been studied is whether non-cardiologists like you and me can do this. I believe we can do this, and I hope that you will develop these skills in the management of your patients with acute heart failure. Thank you again for your attention. I would love to hear your questions and comments, either in the comments section or via email or Twitter.